to just share something that was just on Twitter, and I did copy it to Unremarkable Labs. And it was a friend of mine, Hardeep Singh, who's in Houston, sent it to me. He's one of the leading diagnostic error researchers in the country. And there's an article in the British journal Quality and Safety that looked at people who were readmitted within 7 days at a hospital. There was over 300 patients and why they were readmitted. And about 1 in 20 were readmitted for diagnostic errors. And about half of those were inadequate interpretation of lab tests and not ordering the next lab test, which is why we do this Zoom. That's why we're so obsessed with learning how to interpret labs, because there's a lot of errors of people not understanding how to do that. So if you're on Twitter, you can search under me, or you can search under Unremarkable Labs, because I just retweeted it about 15 minutes ago. So that's my introduction for the day. What we're doing is important.
Great. Well, so thank you guys for joining us on Unremarkable Labs. We've got Dr. Centaur here. I'm Stephen Alon. I'm one of the chiefs here at UAB. I'll be presenting the case. We're joined also by Sean Carter, another chief who'll be running the whiteboard, and Seema Kumar, another chief who is going to help moderate the chat because you guys are busy in there. So I'd love if both discussants, Jacob and Dusty, could go ahead and introduce yourselves. Dusty, if you want to go first.
Hey guys, I'm Dusty. I'm one of the medical students here at UAB. I'm really excited to be here and excited to learn some things this evening.
Great.
Awesome. I'm Jacob Bremen. I'm one of the interns here at UAB. Just shout out Masters, 100 days away. Any golf fans?
PGA is only 2 days away.
That is true. Bama grad's killing it right now. #1 in the world.
All right, guys. Well, let's jump in. So I'm going to give you a case. It's a little different than the ones we've been dealing with before. So the HPI is we've got a 62-year-old woman who comes from her rehab with quote-unquote abnormal labs. So her BMP shows a sodium 137, K 3.8, chloride 97, bicarb 29, BUN 31, creatinine 1.5, glucose 103, and a calcium of 13.9. And with that, I will turn it over to Dusty. Why don't you give us your first thoughts about what you see when you first look at that BMP?
When I first look at her BMP, looks like her potassium is, I think that's low. I'd have to reference check. Trying to calculate her anion gap. It looks like it's, let's see.
Every time medical students have to do math in their head, it's like so painful.
Yeah. So it looks like she does have a gap. No, she doesn't. Just kidding. I don't know. I'm kind of stumped right now. It looks okay-ish, I guess.
Great. You're about to learn a whole lot, Dusty. Let's see what Jacob can do.
Yeah, I'll just follow you. I calculated, so the anion gap's 11, so not really worried about his bicarb is kind of on the high end of normal. I guess the first thing that draws my attention is the BUN and creatinine right here. Mm-hmm. I don't know what this person's baseline creatinine is, but that would be very good to know. But the thing jumping out is the calcium of 13.9. That's I guess almost would be in the severe hypercalcemia category, excuse me.
Okay, so this was pretty tricky, Dusty, because it wasn't part of the fishbone. He was hiding it down there in the bottom corner.
Oh.
It's sort of like when the chest x-ray shows a fractured rib and you're busy looking for the infiltrate. It's magic. Okay, so let's hold off on the calcium and let's talk a little bit about the BUN and creatinine. So your initial thought about that, Jacob, what is your initial thought about the BUN and creatinine?
Let me see. I'm trying to calculate if it's kind of 20-to-1 ratio. Yep. It's right at the 21. It's right at the kind of the cutoff for, is this possibly a pre-renal AKI? Again, I think the most important data point I want to get is her last creatinine to kind of compare to see, is this something new or is this where she lives at?
Okay, so let's talk about the term AKI a little bit, because it's misused by a lot of people. And I highly recommend the podcast that I did with Ashita Talwani on acute kidney injury, where we go over this in depth. Looking at a set of labs at admission, you cannot make a diagnosis of acute kidney injury. All you can say is you have an elevated creatinine and we have to figure it out. According to the guidelines, you need 2 days of trying to fix the elevated creatinine BUN before you actually call it an AKI. Now, with almost any other attending, if you say there's an AKI, they'll shake their head and they really don't care. But the point here, and you really were getting at it, is this looks like volume contraction because of the 20-to-1. And if we give volume, if we decide the patient's low on volume and we give volume and the BUN and creatinine improve, then it wasn't an AKI, it was volume contraction. So in order to say it's an AKI, it has to be for at least 2 days, has to be at least, I think it was 0.3 above the baseline or previous creatinine, and it has to not improve during those 2 days. You have to always think about volume. And the other thing you have to think about, more common in men than women, is obstruction. So if you haven't ruled out obstruction, that's not really an AKI, that's obstruction. So, but you said what you were taught. I'm just suggesting that you think about it in a slightly different way. Now,
there's a robust chat conversation about using the BUN creatinine ratio to assess, is this a pre-renal cause? Do you buy into that, or what are your thoughts?
I'm very suspicious. I'm also suspicious because the bicarb is a little bit high, which you see with volume contraction. The potassium, I wouldn't treat this potassium. There's a wonderful, I think it was Tony Brew did a tweetorial, maybe somebody in the chat remembers, that there's really no reason to treat potassium between 3, 5, and 4. Yeah, it's a little low. That would be interesting. Why would this happen? Why would this patient be volume contracted? Is there a clue here as to why the patient would be volume contracted? Dusty, we're going at you with tough stuff today, but it's okay. We know you're a third-year student, and anything you don't know is an opportunity for to learn, because I'm not grading you. You don't know. So have you learned something so far?
I have.
It makes sense what we're doing so far.
Yes, sir.
This is worthwhile.
I guess I'm curious, like with her coming from a rehab facility, kind of what if that can like contribute towards her volume contraction.
Could the calcium have anything to do with it? Now, why would I ask that question if it wouldn't?
Yeah.
So what does calcium have to do with volume contraction?
I'm not sure.
Good. Jacob, do you know?
So from my understanding, your calcium is going to go up anytime your volume contracted, but also I think elevated calcium can be a driver of polyuria.
Right. So that's actually a very common complaint. Do you remember why you get polyuria?
I wish I could say yes.
Okay. Would you like to learn something?
Would love to.
Okay. I want to see a bunch of chats on why hypercalcemia gets causes polyuria. Multifactorial. Thank you, Austin. That's great. Absolutely, it causes a transient nephrogenic DI. It actually blocks ADH attaching to aquaporin 2. Now, if that didn't cause you to have an anamnestic response, I don't know what would. So if anybody just broke out in hives when I said aquaporin 2, I apologize. So this is actually the classic case that you get when someone's hypercalcemic is they complain of constipation and polyuria. Because high calcium causes constipation and it causes polyuria. So, and it also will cause mental status changes. So we're going to have to figure out why the patient is hypercalcemic. So what would I do if I was on, if this patient was on my service? Well, the first thing I'd do is I'd try to assess volume, because 20-to-1, what's the other reason for very high BUN to creatinine ratio? That may or may not have volume contraction. In fact, if you see 50-to-1, you almost know that this is true. This is actually, this is not esoteric. This is real stuff, and we're getting all the right answers in the chat. So upper GI bleed, because when you bleed a lot, you absorb urea nitrogen from all the breakdown of the blood in the gut. So 50-to-1, think of a GI bleed. 40-to-1, you probably think of a GI bleed. 20-to-1 is usually volume contraction. We don't, you could get it from severe heart failure could cause a high BUN to creatinine ratio. That would be a possibility. Somebody says eating too many steaks. Yeah, anything that would cause you to make absorb more nitrogen, break down more amino acids. So I would check orthostasis. I would see whether or not the patient's had any dizziness. I'd like to know whether or not the patient's tachycardic. If I have a resident who's really into bedside ultrasound, I like getting an ultrasound of the inferior vena cava, just because I think that's better than our physical diagnosis. So we have a reason that we think she's going to be volume contracted, so I'm probably going to give her volume anyway. But now we have to figure out the calcium. How are we going to figure out the calcium?
Dusty, you want to take a shot at it, or you want me to get it?
Yeah, I'd probably get a PTH first, just to kind of go along with the calcium as well as.
Is there something we could get while we're waiting for the PTH that we'd probably get right away that might help us? This is old school, but it's something that CP solvers talk about all the time.
Yeah, phosphate.
So the phosphate, the chloride to phosphorus ratio.
Okay.
Do we happen to have a phosphate, Stephen?
I don't have it offhand, but I know it was in the normal range.
Okay. So let's go through why a 62-year-old might have hypercalcemia. Let's go through the whole list. So we started with hyperparathyroidism. Okay, so there's 3 types of hyperparathyroidism. There's primary, there's secondary, and there's tertiary. Which of those cause hypercalcemia?
Primary.
Primary. What about secondary?
Secondary is typically a normal calcium that's been compensated in situations like CKD.
So it's actually it's usually a low calcium.
Yeah.
It's usually mild hypocalcemia. So what the heck is tertiary? So not a lot of people know what tertiary is. So tertiary is after you've had secondary hyperparathyroidism for a long time, you get hypertrophy of the parathyroids, as opposed to primary, which is usually an adenoma. And then you do a renal transplant, and you get hypercalcemic because they're autonomous. And that's why if when you're on if you're ever on the transplant service, they usually do a parathyroidectomy and put half a parathyroid in the arm if someone's had long-standing secondary hyperparathyroidism, so they can control and not get into the tertiary hyperparathyroidism. Okay, so what's your next big one in the hospital, Dusty? So if number one in the outpatient setting is definitely hyperparathyroidism.
Like chronic kidney disease.
Because chronic kidney disease is hypocalcemia.
I guess like some of the cancers.
Yeah.
Multiple.
Okay, so we're gonna have 4 ways cancer can cause hypercalcemia, and so it's worth thinking about it this way. So let's see how good Jacob can do here.
So, all right, I'm going to go with.
It's a par 4. Let's see what you can do.
All right. So first, I guess it could be PTH-RP related. That'd be
Right,
like
and what are the most common cancers that have PTH-RP?
Squamous cell.
Squamous of lung, but other cancers can do it. So that's a good thought. So that's number 1.
2 would be either primary bone cancer or mets to the bone causing
right.
basically osteoclast activation, like lytic bone lesions.
Exactly. It's halfway there.
Let's
the worst
see.
he's going to get is a bogey.
Yeah, this is tough. There can be some, I think, cancers that actually activate your 1-alpha hydroxylase or whatever it is driving the activation of vitamin D, kind of like sarcoid.
Yeah. So do you have any idea what cancers those are?
I want to say is lymphomas or Hodgkin's.
Yeah, it's actually, so that is exactly what it is. Yeah. And when you think about it, lymphomas and Hodgkin's are almost a granulomatous disease. They're very similar. I think it's macrophage activation. Is that right, Sean? Now, Stephen says that I'm right, so I believe Stephen. Okay, and what's the 4th one?
I think I'm going to take a bogey on this hole. I'm those 3.
No, you got a par. You had a chance for a birdie, but you got a par. Do you have any idea, Dusty? We're getting a little arcane, but this is actually a very, very important one in this woman. Now, we don't know yet, but anytime you have a 62-year-old who's in rehab, you'd have to think about this diagnosis that it's a malignancy. Good, you're about to learn again. Yeah, these opportunities to learn, Dusty, they don't come around every day. What if she was anemic and had some bone pain?
Like multiple myeloma?
Yeah, multiple myeloma. And we used to call it an osteoclastic activating factor. It's one of the interleukins, and I can never remember the number. Stephen, help me. Seema, help me. 6? Interleukin 6? Okay, so we got primary hyperparathyroidism, we've got all the cancers, and we already mentioned granulomatous disease. So granulomatous disease, which is the same mechanism as lymphomas. You mentioned sarcoid, but remember, histo can do it, tuberculosis can do it, and I've seen both of those do it. And berylliosis, there are a number of different granulomatous diseases. Let's think of other endocrine diseases.
Hyperthyroidism.
Hyperthyroidism, that's correct. And so knowing a pulse on this lady might help us. And I've seen that a couple of times. It's not really usual, but a 62-year-old might present with hyperthyroidism just with isolated tachycardia and not any other symptoms or physical findings. So it's definitely worth having on there. There are a couple more.
So basically hypervitaminosis D, or basically
that's not an endocrine, but you're right. But it's classic. I always like interns who answer the question that they know rather than the question that I ask. Sabina, I don't think that one is.
would you, I don't know, I think this is more renal, but I guess would you classify this under endocrine as like a familial hypercalcemia?
No, no, that's just a familial, it's just IHH. Okay, so Addison's will do it. And I'll give you a clue. The Princess Bride.
Acromegaly.
Acromegaly, right. You're never going to forget that. That's going to stick in your head forever. Lady, lady. He was so brilliant in that. Okay, let's talk about steroids, because somebody thought that Cushing's might cause it. So what's the treatment for hypercalcemia with granulomatous disease? Is steroids. And the reason is because steroids block vitamin D associated absorption of calcium from the gut. That's one of the reasons that people who have Cushing's or people who are on steroids get osteoporosis, because they have less absorption of calcium. So you can think of it both ways. And Addison's doesn't cause very much hypercalcemia. Okay, what might this patient take on their own that would cause hypercalcemia?
If they were taking like thiazides.
So thiazides, but we prescribe the thiazides. Thiazides are a very, very minor cause of hypercalcemia. It's on the list. If it really causes significant hypercalcemia, you better still look for hyperparathyroidism. And it was much more common back when we used much higher doses of thiazides than we do today. So I actually never see that. There's another medication that we would prescribe that could cause hypercalcemia, but there's something that they would take over the counter. And the chat is on fire. They're so excited about it. Okay.
Milk alkali syndrome from basically taking too many Tums.
Right. So, and it turns out that milk alkali is the third most common cause of hypercalcemia in the hospital. Everybody forgets that. Do you know why it's called milk alkali?
I don't.
So it has to do with the sippy diet. Have you ever heard of the sippy diet? Of course not. So the sippy diet was very popular in the 50s, 60s, and 70s. It was an ulcer diet. Dr. Sippy was a surgeon. And when I was in medical school in the 70s, ulcers were caused by too much acid. This idea that there was a bacteria, that was really stupid. I don't know whoever came up with that. So what they would do is they'd ask for frequent feeding 6 times a day with a lot of dairy and take Tums. So it was milk and alkali, taking Tums plus milk, and they'd get hypercalcemic. Then in the early part of this century, there were a lot of women who got it because they were trying to self-treat to protect against osteoporosis before we figured out that too much calcium, too much Tums leads to coronary artery calcification, coronary artery disease. So we don't do that anymore. Now why do most people self-medicate with Tums? Got you on that one. Actually, it's mostly people with reflux, self-treating heartburn. And some people take a whole lot. And I've even had patients who took it because they like the taste. I had a guy who, what he told us is that he had a candy bowl with a bunch of Tums in it, and he'd just go by and eat a couple all the time, and he came in with a calcium of 14 or 15. And I've seen calcium as high as 15 from milk alkali. Let's see, did we have IHH up there? I think. What was the other medication? Let's say this lady also sees a psychiatrist.
Lithium.
Got it. Yeah, so always keep lithium in there. God, I know I'm forgetting something.
Did we talk about like just patients being bedbound for too long and not moving around, causing hypercalcemia?
Yeah. So which patients? So usually you also have to have high bone turnover if you have if you're just bedbound. So there's two groups that I was taught. So there's a particular disease of bone with very rapid turnover that's not pronounced properly in the United States because it's really a French name. And the chat's going nuts. It's Paget's or Paget's disease. And very unusual, but I actually saw one when I was a resident, adolescents with long bone fractures. Since adolescents have such rapid bone turnover, what happens if they have a long bone fracture and they're bedbound, they are turning bone over quickly, just like people with Paget's disease. FGF23 rickets. Drew, that sounds definitely like a pediatric thing. This lady's 62, Drew. Familial hypophosphatemic rickets. Okay. Is there anything else that I left off the list? Great chief residents?
I think y'all nailed.
You think we nailed it?
I think y'all, I mean, there may be some esoteric zebras out there, but I think y'all got the big ones.
Yeah, and remember, hyperparathyroidism could be part of a multiple endocrine neoplasm problem. I think the chimpanzee has zoledrellicin, but I don't think zoledrellicin really causes it. I think there has to be associated hyperpara, but if you use chimpanzee, I think it's in there. Okay, so what were you going to say, Stephen?
I was going to say, you guys have a wonderful differential here, and I was just curious, how are you going to narrow it down?
So Dusty wanted to order PTH, and I'm in favor of that. What else do you want to order?
I would like to order a physical exam and vitals first, and then.
Okay, that's a good intern. He might be quarantined, but he's still thinking. Okay, so. And let's get a past medical history. I mean, why is she in rehab? So if we know more about her, we might have some clues. So can you reveal? But of the tests we're going to get a CBC. We may well get an SPEP depending upon the CBC and whether there's a gamma gap. Although I've seen myeloma without a gamma gap. We're going to probably get a PTH-RP. And you need to get a 125 vitamin D. You don't get a vitamin 2, you have to get the whole 125 because what you're looking for, we left out, there's one other vitamin besides vitamin D, and that's actually important. And this is important to Drew because he wants to be a pediatrician. So it's vitamin A, and why should Drew care? So why do adolescents sometimes get hypercalcemia? So they take something that's made from vitamin A for their acne.
Accutane.
Okay. Okay, so we're going to take a history. Find out whether or not she's eating Tums. Is she taking supplemental vitamins? She heard vitamin D was bad, that she had low vitamin D. Her doctor told her to take vitamin D. She figured instead of taking what he said, taking 8 times as much is better. We'll get all that history. So Stephen, you're now going to reveal a lot to us.
Yeah, I'll give it to you in buckets. So as far as her HPI, you guys want a little more. So she doesn't take Tums. She doesn't take any supplemental vitamins. She The reason that she's in rehab is she was actually hospitalized because she had a total hip arthroplasty that had a joint infection. And so they had to remove that. And so now she's going to rehab to get stronger. As far as her physical exam, she's well appearing, resting comfortably, mild tachy to 105, but otherwise her vitals are unremarkable. And she does appear a little volume contracted on exam. Her lips are dry and, decreased skin turgor. But otherwise she's
which are not very good signs of volume contraction, but
sure. And then as far as her labs, so her CBC, her white count is 5, hemoglobin is 11.8, platelets are 273. And then you had mentioned as far as albumin and a protein to get at the protein gap. So her albumin is 3.5, total protein is 6.4. Her PTH is 5. PTH-RP is undetectable. Her 125 vitamin D is 27, which at this lab is in the normal range. And then her vitamin A is 31, which is also in the normal range.
So we have a heck of a mystery, don't we? Okay. So let's go through these one at a time. So let's talk about the gamma gap first, because I asked a question on Twitter and got a whole bunch of information back on the gamma gap. Have you heard of the gamma gap, Dusty?
I haven't.
It be your first opportunity to think about the gamma gap.
First opportunity.
So total protein minus albumin is the gamma gap, because what's not albumin is mostly gamma. Anything above 3.1 is not good, and you have to at least think about it. A lot of people say 4, above 4 is abnormal. If there was an increased gamma gap, then we'd get an SPEP to see if it's polyclonal or monoclonal. A lot of inflammatory processes will give us polyclonal. So the gamma gap is very nonspecific, but it means you need to at least think about it. This doesn't really catch us, although we still may look at it because you didn't write down the CBC, but she is a little bit anemic, right? Her hemoglobin's 11.8, I think you said?
Yes, 11.8.
Okay. So 11.8, that's slightly anemic. We don't know what she was before. It doesn't scream anemia to you, Drew. Do we know what she's been running? We were also asking for her old labs.
Yeah. So this is close to her baseline the past couple of years. Hemoglobin of 11.8. Her baseline creatinine over the past several years is 1.1.
Okay. So we don't think we have hyperparathyroidism. She definitely doesn't have malignancy causing PTH-RP. She doesn't have a granulomatous disease. She doesn't have too much vitamin D toxicity. She does have tachycardia. What did we not order?
EKG.
So I think you have to get a TSH. Now, she's probably tachycardic because she's volume contracted. So I'm going to give her some volume. Now, the chat was going crazy over whether we're going to give her saline or whether we're going to give her a balanced solution. And this is one time where you actually want to give saline. And the reason that you want to give saline is because she has metabolic alkalosis. And that's a chloride problem. So I would initially give her some saline. I like using balanced solutions a lot, but this one particular situation, I think saline might be a better idea. So I guess what I'd do is give her some fluids see what's going on, order a TSH, a free T4, because I didn't check that. Do I need to check her blood pressure was fine?
Yes, it was 130/70.
Yeah. So I don't really have anything going for Addison's disease. If I was really compulsive, I might order a random cortisol, but I don't think it's necessary. But if somebody decided they really wanted to do it, it would be okay. So I want to see whether her renal and maybe a urinalysis. Do we have a urinalysis?
Yeah, her UA's bland. There's 1+ protein. Otherwise,
Does she have a specific gravity on that urinalysis?
I do not. I know you wish I did. I'm sorry.
Okay, so Dusty, what did I want a specific gravity? This is, you're learning so much tonight.
I am.
And some of this stuff is going to be on the quiz. Okay, the urine specific gravity is a way to think about whether the urine is concentrated or dilute. Now, I thought I really wanted it because I think she's volume contracted, but then I realized that she probably has nephrogenic DI, so I don't know what the hell I'd do with the specific gravity. But I like saying that I want the specific gravity. But here, I don't think it would help me. So I think we're just going to have to give volume and see what happens while we wait for the TSH.
Yeah. So you give her some volume. You give her 2 liters of normal saline. Her heart rate does improve to the 90s. Repeat calcium is 13.8. And her TSH is 1.5 with a normal free T4.
So now we really have a mystery. So let's go back through all of the things. Have we ruled out parathyroidism? Her PTH is actually low, which it should be with hypercalcemia. If it was normal, we'd worry about it. PTH, RP, vitamin D is normal. So maybe that's actually high for someone who's hypercalcemic. So I have to go back and look and see whether or not we have to think about vitamin D. Because remember, we're talking about unremarkable labs. So we think that's unremarkable, but is it really unremarkable? The vitamin A, it was way out of bounds anyway. Maybe an alk phos to see whether or not she's breaking down bone.
Sure. Alk phos is 105.
Okay, so that's against that. Is it still worthwhile to look for multiple myeloma? What did her BUN and creatinine do with volume?
Yeah, they both improved. So her creatinine went to 1.3 and her BUN went to 24.
Okay. So is it worthwhile to still look for myeloma? I mean, 11.8, yeah, it doesn't excite most people. And she's been there for a while, but myeloma can be a slow process, and I'm having a hard time finding anything else right now. I mean, this is sort of like Sherlock Holmes' favorite one of his favorite quotes. When you rule out everything else, the last thing on the list, even if it's most unlikely, could actually be the answer. I doubt that she has acromegaly. Now, in rehab, was she walking or was she just lying there?
She was doing a lot of upper body stuff. So when they replaced her joint, they actually just put a spacer in. She doesn't have a full joint, so she can't bear weight.
Yeah. So I don't know if that's enough lying around. So I think I'm still going to get an SPEP and a UPEP and all those other fancy tests you get for myeloma, because I'd hate to miss myeloma. And anytime you have these numbers, you have to think, could it be myeloma?
Yeah. So you get an SPEP and a UPEP. There's no M spike. The FLC ratio is 1.2, which is mildly elevated.
Which is mildly elevated.
Yeah, mildly.
So where are we going? We've really looked at a lot of possibilities. routine things like chest x-rays and, bone scan, maybe. I mean, really, really unclear.
I know we didn't get a ton of history, but if she's had any like call for shortness of breath, would it be worth getting a histoantigen at this point?
Okay, well,
Yeah,
let's get a chest x-ray.
Yeah, so no cough, no shortness of breath, chest x-ray shows clear lungs, no cardiomegaly, no bone fractures or lytic lesions.
And she'd had was this a chronic hip problem, or why did she have the original hip replacement?
Yeah, so she just had chronic osteoarthritis of her hip and had it replaced, and then subsequently years later it became infected. She was septic, admitted to the hospital, and now is in rehab.
And what antibiotics was she on?
So the culture grew out Staph aureus, so she's just on vancomycin.
Just on vancomycin.
Mm-hmm. And one thing that I'll point out that's interesting is when she was in the hospital 2 weeks ago, her calcium was normal. It was 10.3.
Calcium went from 10.3 to 13.9, and we have thought of an incredible number of things that are not getting us anywhere. Is she on vitamin D by any chance?
She is not.
She's not on vitamin D. So we've ruled out. We haven't ruled out acromegaly, but that doesn't make any sense if she was normal.
Yeah, on physical exam, there's no signs.
Yeah, we haven't ruled out Addison's. Still concerned about granulomatous disease, but other liver tests are normal.
Yes.
Other liver tests are normal. Let's see. I got to minimize this so I can just make sure that we're not missing anything. So now I know how to work this stuff up, and I'm really having a hard time this time. Could it be like an occult granulomatous disease? Her vitamin D is normal. It should be elevated if that's the cause. So I'm having a hard time coming with granulomatous disease or lymphoma.
Bob, you mentioned the liver test. There's a question. Was there something you were thinking if the liver test is abnormal?
I'm looking for a place for granulomatous disease to hang out. I am really scrambling here to try to figure this out. Yeah. And the question is there a lymphoma hiding someplace? If it was a lymphoma, it should be a high vitamin D. So what I'm not sure about should this vitamin D be suppressed because of the hypercalcemia? And is it still a vitamin D problem that we're missing? The PTH is appropriately low, so I can't go there, and I can't get to PTH-RP. But the vitamin D is elevated. Now, why would it all of a sudden be elevated? They didn't put her on lithium.
Nope.
And did they start a thiazide for some reason?
They did not. But you guys, I'll say, I love that y'all have gone through this differential. I have never seen a differential that includes the cause for her hypercalcemia before. It is quite rare, but you're asking all the right questions. You're noting the acuity of the change, and is there something that we did to her that caused this? And the answer is yes. Unless you have other thoughts, Dr. Center, I was going to sort of give you all the answer.
So when they put the spacer in, was there anything to do with calcium in the spacer? Exactly.
Yes. So you nailed it, Dr. Centaur. So this is actually on the level of case reports, but the spacers that are placed in joints after a septic joint, they're actually antibiotic spacers, and they contain calcium sulfate antibiotic beads. And so in rare patients, this calcium can actually be leached and leak out into the bloodstream, and it causes a transient hypercalcemia that lasts up to a couple of weeks. Self-resolves. All you have to do is supportive management. And her calcium within a month had normalized. She did well.
That is absolutely wild. That is absolutely wild. Okay, so Dusty and Jacob, I want you to come up with 2 things that you learned today that are going to help you, and share them with share them with the chat room. I hope everybody in the chat room is actually writing down 2 things that they learned that they want to use, other than the spacer thing, which is like really crazy.
I will say I will never forget to keep acromegaly on my differential for hypercalcemia now. And also Addison's. I guess that's one thing I just didn't have on my differential from the get-go. So that was good to put in my head.
Dusty.
Just learning a little bit more about the history of the milk alkali syndrome. Just didn't really know like how a lot of that got its name.
Yeah, most people your age don't know. It's only people my age who know that.
Yeah, and then just generally like the work, we spent a little bit of time on the workup for multiple myeloma. So just really diving into like what that workup looks like besides just basic labs.
Great. And Seema, you get to have the last word.
Yeah, so I will try to hit some of the high points that we talked about. So we started talking about the diagnosis of AKI. We all have now homework to listen to a podcast with Dr. Centaur and Talwani. But for the diagnosis of AKI, what you really want to see is that in addition to being a 0.3 above a previous baseline, you need 2 days of trying to fix an elevated BUN creatinine before you're going to call it an AKI, and it has to not improve during those 2 days. In talking about hypercalcemia, we explained the physiology behind the polyuria, and that is that when you are hypercalcemic, it's blocking ADH, which is attaching to aquaporin 2. We delved into the BUN creatinine ratio. We talked about how in this patient, where it was closer to 20-1, we think about volume contraction, and very high ratios like 50-1, that's going to point us towards an upper GI bleed. We really went into the differential for hypercalcemia. So I'll just run through some of the things that we mentioned to remind ourselves. So first we have hyperparathyroidism. We went through primary, secondary, and tertiary, and when to think about which ones are associated with high calcium versus low. Malignancy, we talked about the 4 ways malignancy can cause hypercalcemia. So PTHRP, primary bone or metastases, lymphomas or Hodgkin's, where you're activating vitamin D, and multiple myeloma. We also mentioned granulomatous disease, hyperthyroidism, Addison's, acromegaly, milk alkali, lithium, and immobilization. And with immobilization, we talked about adolescents with long bone fractures and Paget's. I don't know if I said that right. I may have butchered it all the same.
I think that's the way they say it in France, but I'm not sure.
Okay. We discussed the gamma gap, and that you calculate it by taking the total protein and subtracting albumin. Anything over 3.1, we want to think about, though I guess that magic number is 4, where that really, we're going to say it's abnormal. And if it's elevated, we're going to get an SPEP to see if it's a polyclonal or monoclonal gap. And then finally, with this specific case, we talked about how because this was a metabolic alkalosis, which is a chloride problem, we were going to give saline, which is maybe a little bit different than our usual goal of giving balanced fluids, but this was an exception to that rule. So I think those are some of the high points. We discussed a lot.
Great. And because we're just a touch early, if anybody in the chat has any questions, if anything wasn't clear, please type them in the chat right now. I'll be glad to answer them. So hopefully we were relatively clear this time. We probably are not going to be able to do one next Tuesday because all of the chiefs have a special dinner. So Austin asks, when do I believe the BUN to creatinine ratio? When the BUN and creatinine come down with volume. So I think it's a great clue. I think it's an absolutely great clue. Alexander Smith says, how sensitive is the chloride to phosphorus ratio? It's really just a trick. We're going to get a PTH anyway. That we used it a lot before we had PTH. But if there was we had a similar, we had a case of recently where the chloride phosphorus ratio was 50, and since anything over 33 or something is abnormal, it was a real good sign that it actually was hyperparathyroidism. So Austin, you think I'm cheating? I believe it, but then I have to think about the patient, because nothing is really good for volume contraction. Volume contraction is really hard to diagnose. You're going to make mistakes on it all the time, but I believe it enough to give volume if the BUN to creatinine ratio is above 20. But I'm not marrying to that. I'm not marrying that diagnosis. As one of my colleagues said, it's okay to date a diagnosis. You can spend the night with a diagnosis, but don't marry a diagnosis till you're damn well sure. Thank you all for coming. We do have a return for Jory May in a couple weeks for hematology, and we actually have one of our liver docs who's going to come, and she's going to go over liver tests early in September. So we're going to branch out with a lot of other tests that hopefully will help you. We really appreciate everybody who shows up and everybody who subscribes to the YouTube channel, and we hope you're giving something back in return.
And big shout out to Jacob and Dusty for being our discussants today. It's never easy to sit in the lukewarm seat, so we appreciate y'all.
Yeah, and he gave you a really hard one.
Yeah, and Jacob, I mean, he came back for punishment, so
yeah.
Here we are. So we'll miss you guys.
He's so bored being quarantined. He can't even go out and play golf because he's actually quarantined. I mean, it would be so bad if he could.
This is the highlight of my quarantine tonight.
Yeah, this is a highlight of your quarantine. Yeah.
So we'll miss you guys next week, but looking forward to starting back in 2 weeks.
You learn golf terms, Austin?